Okay, thank you so much, Dr. Larsen, for the introduction, and thank you to the organizers for having me out. I'm humbled to be a part of the summit, my first time here, and connecting with a lot of new dynamic colleagues. I hope you'll find what I have to say about AI interesting or worthwhile, maybe a little bit scary, and that's okay too. The title for this talk is kind of a play on the book Flowers for Algernon, which is a little bit of a deep cut. Hopefully there's some folks that have read the book. It may be a better bellwether for generational divides, but if you don't know the book, it's about a lot of things, including protagonist Charlie and a mouse named Algernon who have a surgical procedure that makes them smarter. And spoiler alert, but the book's from the 50s, so I feel like you've sort of had your chance. The procedure wears off, and there's lots of other bad things that happen as on the backside of that. And I thought this might be a useful allegory for what are potentially some of the things we should guard against when we usher in AI and these new technologies. So my conflicts of interest, I'm involved in this space in different ways and could potentially be replaced or affected. So I am not an uninterested party. I do have a feeling about this space. So AI is going to do a lot of things that we maybe didn't think about, but I also think of it as a layering technology. So I think it's going to touch all parts of the profession, which I think has been echoed across a lot of these talks the last couple of days. I was asked to speak about AI in consulting in veterinary radiology, and so you probably jumped straight to, well, image analysis and making diagnoses, and that's certainly happening and will probably continue to happen. But I'd like to sort of think of it from a little bit more of a holistic perspective, which is really going to start with the pet parent or the human companions to our pet patients, all the way through the chain until it gets to a consultant, whether that's a radiologist or a clinical pathologist like Dr. Chu or a neurologist or your colleague down the street or whoever it is. AI is going to touch all of those parts, and if we do it correctly, we'll make that chain better and more efficient and hopefully more accurate. I probably won't talk much about research. You've heard a lot of that the last couple of days, but I'll try to hit these other points and give you my sort of vision of where I think this will go, which I think has been echoed by some of the other speakers. I've used AI to create sort of a comic strip to tell you this tale, because I think as humans we learn through storytelling, and also it is evident in how powerful AI can be, which you've also seen some examples, but also some of where it still falls down a little bit. So again, I think this is going to start with the pet parent, and this is really going to be empowering the pet parent to be much more involved in the care of their pet. That's going to be using their phone, applications, that's going to connect to wearables and some of these other technologies that you've heard about. That's also going to be direct input from the pet parent into these devices, so that there will be this continuous acquisition of data. Some of this you heard from Dr. Kusi. Temperature, pulse, respirations, weights, what they're feeding, did they hit all their medications that they're supposed to get, are there behavior changes, was my pet scratching their ear last week, or did they just vomit? And so it's not, oh, my pet's been vomiting for the last 2 years and now we're coming in, right? So that acquisition of continuous data is going to be very powerful. The other thing that's going to do is owners are going to have their entire medical record in their pocket, and they're going to want that, right? So there's going to be a little bit of a decentralization of things away just from hospitals, I predict, and they're going to want to be able to go to the ER place and have their complete medical record and not waiting on it to shift from another medical record system. So that's a very powerful thing, and they're going to be using this to be making assessments of their pets. People are doing that now. Right? You can currently put in PDFs of blood work and imaging into some of these language models and other vision models to get information back. Whether that's validated is a whole question we need to be careful about. But they're going to be doing that, and they're going to be taking pictures of vomitus and poop and diarrhea and pee and videos of their behavior and them scratching, and they're going to be getting some sort of information that probably initially will skirt the line between diagnoses and practicing medicine, but that line's going to get really blurry, and as I think you've seen, particularly in some of these models and examples, these things are changing on a daily basis. So if you're not watching the space weekly, you're not up to date, because things could change overnight. So when that patient enters the hospital, they're going to have a unique identifier. So that might be a microchip, but in a new world, that might be powered by blockchain technology, and that's going to be unique to them. And as soon as they walk in the hospital, that's going to get scanned. And all of that information that's in their phone or their app is going to get immediately shot to the electronic medical record system once we figure out how to get all these systems to talk to each other, right? And so before they even come in, that's going to pre-populate a lot of the paperwork. You can start to see where there's efficiencies at a veterinary hospital all the way from check-in to taking histories. And by the time they go and speak, hopefully still to a human being, although that could change, they're going to have that information, and that might become more of an experience of checking the box of is everything that has been pre-populated correct, peppering that with additional questions on the history to make sure that there isn't something that has been missed. And then being more time doctoring, being present with the patient, right? Forming that bond. That's still something that we can add that a computer can't, at least for now. And that's going to streamline that whole process. Again, getting away from medical records and the more monotonous tasks and letting you leverage your unique expertise. And you've heard a little bit about this already, these ambient technologies that will listen in the room and populate SOAPs and differentials in your medical records. Certainly this has been used in radiology for a long time. Even if you're not using an ambient technology, if you are not dictating your reports, you should start today. Okay, it is imminently faster than typing, even if you're not using AI beyond this natural language processing. And those are other things we might want to look at, is are these ambient technologies any better than you using a dictation software to create records? Is there even a value add? Have we created a different outcome? But so that whole system is going to be streamlined. And the key, even with some of these ambient technologies, is we have to make sure they're validated. Because there will be, the other lens that I'm going to offer to you is as dressed up apes, we have the same wetware, no matter how smart we are and how smart we've made ourselves through study and training. And we commit common errors as humans, right? And so something listening in the background will change the way that you actively listen in a room for all of us. Okay, and there will be an atrophy of skill set as we start to rely on some of these other technologies. So how do you safeguard against that? Now you might notice if it's populating your medical records that it said Lorax instead of thorax, but will you notice an error of omission where that patient is on 10 medications and it happened to miss 9 of 10? And there's going to be gremlins and errors that persist in those medical records. So we need to, as a profession, think about how do we protect against that to make sure these things are validated and those errors are not getting promulgated throughout records and treatment and errors, because at the end of the day, it's your license, right? And you are responsible if you're using those tools, at least in the current landscape. Also from the veterinarian side, one of the barriers to submitting for a consult, whether it's to me or someone else, is filling out the paperwork, navigating that new interface, putting in the signalment and history, which doesn't always happen, and then that leads to a poor output from the consultant. And so AI could be used to gather all that information that came from that unique identifier and the ambient technology and the medical record that's been created, and auto-populate the consult that actually has a proper signalment, history, pertinent clinical information, the clinical question at hand, and these are all things that improve the accuracy and efficiency of the consultation that you get. Right? We get things that might have no history, or we might get coughing, or I might get 50 pages of medical record, which I will not be reading. I hate to break it to you. Right? And all of those things drain the system, especially when we have a paucity of certain specialties and consultants, like in radiology. Right? So these are all places before we get anywhere close to diagnosis that improve patient care and access to care. It's also going to be helping in quality control. And so that could be prompting, hey, I see that you have talked about this in the room. You need to get a 3-view abdominal radiograph. And then when you get that radiograph, there'll be things at the coalface at image acquisition that tell you this is a diagnostic study or a non-diagnostic study. This is well positioned or poorly positioned. Inspiratory, expiratory. The legs are over the thorax. There's a hand in the beam, right? All things that I see on a daily, weekly basis, even though we don't teach it that way anywhere, right? Understanding the reasons why it happens, right? Training, staffing, time, all of these things that push towards a less good product, right? But it's garbage in, garbage out. And instead, if it came up and it's poor positioning or an expiratory thoracic radiograph or it's rotated, that is photoshopped from an actual radiograph that I have, just FYI. And I have a whole archive of these. They're not uncommon. But one, there's safety implications for staff that may not even know they're exposing themselves. But also for an owner, right, you get a better quality study that you've paid for. And I can tell you that whether you're a radiologist or not, having a well-positioned, well-exposed, inspiratory 3-view thoracic radiograph is a better test than 8 images with the legs like this and they're rotated because the dog wasn't sedated or wasn't able to have good radiographs taken. It's more time in the hospital, it's stress on the patient, it's a poor test that you're charging an owner for, right? So all of that would be, if I was king for a day, I would stop the talk here, and these are all the things we should do before we even get to diagnosis. And there's lots of other reasons why I feel that, which I will tell you next. But so that's sort of the first part of the chain before it even gets to a consult. Because even if it doesn't come to me and you're interpreting your own things, you will have a better chance of getting to the right place with a better test that is actually a diagnostic test and complete. And it will make the staffing and the time in your clinic less. So my first treatise to you is that we are going to create super pet parents. And this is going to be very different than Dr. Google. And I hope some of the things that you saw in Dr. Lundgren's talk in the last couple of days are proving this to you. I'm certainly hopeful that we don't get replaced, but people will have a veterinarian in their pocket that isn't that much different than the opinion that you can offer, and that will happen pretty quickly. It's nearly here. Now, used correctly, these things will foster the relationship between veterinarians and pet parents and the pets. Incorrectly, and we will get sidestepped, and we will not be very happy for that. Okay, but owners, it's not the same as Dr. Google. These things will remember prior conversations. Language models now will reference your prior questions. They'll tie in that all together. You'll be able to feed in your blood work and your imaging, and it'll have everything in there. And you should start asking yourself, what is the value add that you will be bringing to the table in that scenario? And how do you avoid yourself just being medication and procedure dispensing machines? So sorry to be sort of like the sad sack in the room, but like that is a potential outcome if we don't guard against it. Now, done correctly, we'll have super pet parents that'll provide us better information with continuous data that's more accurate. All the paperwork stuff will be easier. We can spend more time doctoring. Consultants like radiologists will also be supercharged because my accuracy is better for a diagnostic study than I have to read through 12 thoraabdomens. And friends don't let friends do thoraabdomens, just so you know. Right? My accuracy gets better. And so think of a different world. Instead of the current paradigm, if we talk about products that look at images, which are currently assessing things for diagnoses or signals or whatever semantics they choose, if instead we think about what if we leverage this technology to move us to a new standard of care, where if I can be 30 to 40% more efficient, that drives costs down, right? There's not enough radiologists, not everyone can afford a consult, all of these things that are obstacles. What if we leveraged AI to overcome those? What if we were in a world where everything could be assessed by a radiologist? And wouldn't that be an interesting place to get to? And I think AI is something, if we use it correctly, that could get us to that place. So it will get to diagnosis, and these are products now that will look at images and give you some sort of an output, whatever they call it. And that will continue to come online. They'll continue to get better. Again, as I mentioned, radiologists have been using natural language processing, dictation products, for a very long time. It's much more efficient than typing. You can build in macros and templates and active fields you can move through to have a mix between active talking and things that you say all the time. And the outcomes assessment is the other thing that we need to look at, because I would offer you that I bet you with a good study, like I'm actually much faster than an AI product, okay? Currently at least. Now, currently these products I would dictate, speak about the findings, and that populates a report, and then I got to go synthesize that and talk about my opinion or conclusion and my recommendations. Now, another place that I would use this instead of offloading the diagnostic piece is maybe I'm having AI that's trained to me, and all I do is have to dictate my findings, and the AI knows how I would synthesize that into an opinion and recommendations, right? And it's doing it in my style, in my voice, and now I'm spending 50% less time writing my records, right? Again, drives costs down, improves access to my particular specialty or consultation. Ideally, these things with AI would also be powered by predictive values, and here's a reference for why I think this is aspergillosis in this bird's air sac or not, right? That an owner could then reference if they wanted to pull that up, or the veterinarian, or want more information, and then I can spend less time inserting those into my reports, which I do when they're applicable, right? So these are all places where, in a world where we're not getting replaced, but we are augmented, these would be really useful augmentations. Now, I want to offer you this lens of our cognitive biases as we think about AI, because if used correctly, AI is not reliant on or susceptible to the errors that humans can create. But if we use this incorrectly, it can make our cognitive biases worse. Okay? And so there's a lot of cognitive biases, also called cognitive dispositions to respond. But A couple of these that are relevant to AI are premature closure and satisfaction of search. These are forms of tunnel vision. So you make a diagnosis and you stop thinking, right? There could be multiple problems, or maybe that's not the right problem. Diagnostic momentum is essentially peer pressure. So this is someone else said it, an esteemed colleague, it's in a record, and you are more likely to agree with that decision as a human being, regardless of your level of training, right? There's some variation there. There's a higher threshold for you to disagree when someone else already said it, just as a human component of how we have evolved. An automation bias is a machine, or in this case, AI said it, and then you are more likely to take it as truth, right? So we might think that we won't do that, and I'll try to prove that that's not the case. But when that printout comes, that seems official, and if you are using these tools to be efficient, right, it takes effort, and it makes you less efficient to double check them. And behaviorally, that's simply not what people are going to do once they have decided that they are accurate. Now, this isn't just my opinion. This is a recent human study looking at human breast cancer on mammography. So this is a very standardized test in a single body part of a single species, which is not what we do. And to set this up, they looked at domain experts, so radiologists that just read mammograms of 3 levels of experience: early career, mid-career, late career. So different forms of experts. And they were either given a mammogram with nothing on it, a mammogram with a heat map where AI is saying, here's where I think the cancer is, or with this text, which I know is hard to read. This is the BI-RADS category, which is the staging scheme for human breast cancer. So either plain images, images with heat map, or heat map plus, here's the BI-RADS category. And they set it up so that some of the data set was wrong on purpose, because we're assessing automation bias in domain experts, which is not the standard of care in our profession, okay? And just to walk you through this, so with the help of AI, so here's little baby Yoda as our early career domain experts, Yoda, and then juvenile Yoda as our intermediate experts. That should give you some sort of feelings inside. And when AI is doing what we want it to do, right, so when it's giving us the right answer, everybody does pretty well. This is not statistically significant, but you can see there's a tighter spread for experts. When AI behaves badly and gives us the wrong answer, you can see that everyone does worse, yeah? There is a protective effect for the experts, okay? Furthermore, when AI says you have worse cancer than you really do, everybody is biased, but you can see that the experts are less biased. When AI says you have better cancer than you really do, which also isn't good, but is potentially less dangerous, again, everybody is biased, but experts have a protective effect, okay? And so I would like to remind us that human medicine is very different than what we do for a couple of key reasons. And one is that we can euthanize our patients, yeah? And these are the patients that will be euthanized from those decisions. And so extrapolate from this to non-domain experts. We don't have that study, but I think it's reasonable to presume that you're not going to perform better than experts, right? And so that, coupled with the fact that we have no regulations for these products, okay? And so when Dr. Lundgren said that we are frictionless, this is why we're frictionless, okay? So on the human side, these are regulated by the FDA. They're medical devices, or a category of software as a medical device. There is a huge loophole on our side, which maybe you all know about, maybe you didn't know about. That's concerning. So there is literally no regulation of these products coming to market, and we can euthanize our patients. That, to me, is a very concerning combination. So we need to safeguard against that. Now, in the EU and also the FDA, they have introduced a risk stratification scheme, right? Because maybe something like a wearable like an activity monitor is a pretty low risk category. We don't want to stifle innovation, so we're going to look the other way on those things. But for things that are medium to high risk, which is really anything that monitors your physiology, up to eliciting a surgical intervention or deterioration of health, or death, or a permanent deterioration of health, is medium to high risk, and then the FDA, the EU, is not going to turn the other way. You must be regulated. You must meet certain benchmarks and obstacles to get approved and hit market, okay? That's not true for us, but if we look at veterinary medicine and take some examples of some of the products on the market in radiology of what they will diagnose or offer as signals, right? These are all reasons why a patient gets transferred to whatever comes after. And I'm sure, as veterinarians, you have all had patients that have diagnoses like these that lead to euthanasia because of suffering, owner finances, access to care, all of these things. So I would offer to you that almost everything in our profession is medium to high risk and therefore should be regulated, but it's not. And that's why we as a profession need to guardrail against these things. So this is going to affect teaching as well. There's a paucity of radiologists for all sorts of reasons, largely market forces. There's lots of universities that don't have radiologists or have a skeleton crew. These will be increasingly used to augment that. Okay? And so everyone is going to be walking around with whatever specialty you want in their pocket. It would behoove us to make sure that those are validated products and information. I'll just offer you this as a movie, Real Genius from the 80s, which I think is kind of prescient. So real smart kids that are kind of an analog of MIT. And first scene is lecturer lecturing to a bunch of people in the audience. Next scene, the lecturer is lecturing to a couple of students and some tape recorders, more tape recorders, and then the smash cut to a reel-to-reel giving a lecture to a whole bunch of tape recorders. And this is in the 80s. If anyone works in academia, you know if you get 30% of the class showing up with lecture capture and everything, you must be a dynamic speaker, right? And this is going to continue. So again, what is your utility? What is the value add for someone showing up to hear you instead of their personal tutor that they can listen to at the gym on the treadmill? Okay. Now lastly, I just want to talk about regulation. I think I'm running on time here, but we need to decide what AI is, right? Because our regulations and rules were not made when AI was a thing. And maybe it's just a tool, and maybe it's conscious or will be or already is, or who knows. But if we think about the veterinary client-patient relationship, and we think about what comprises that, which is in part owner consent and ability to treat our patients, and follow-up and knowledge of the patient, a lot of these things, based on some of the tech you have seen, I think you could imagine a world where AI could meet a lot of those requirements. We may not like that, but I can tell you that from a business side, there are people who will try to solve for that, okay? And also the stripping of the in-person exam from the VCPR, which is already in multiple states, is going to facilitate that as well. And if we think about consultations and referrals, right? If you need help on a case or you want a consult or a radiologist report, you know, you can seek an opinion, we exchange information, we can obviously have a conversation. A referral, you're transferring the VCPR and you're also transferring the responsibility of diagnosis and treatment. And so if you're using an AI where you don't actually know how it works, there's no information for you to vet the product, we have to ask ourselves, is AI a consult? Is it a referral? Is it just like using a blood machine? Can it hold a VCPR? How do you feel about that? These are all things we're going to need to wrestle with. And so just to bring it back for flowers for Algernon, I would just like to offer to you that this is a potential outcome. I don't want this outcome, and it may not be best, but we might end up there. Things could get real weird. And so there might be this new flower of knowledge, but it might wilt our critical thinking as we rely on these tools. So I'll just lastly end on this quote by Paul Virilio, who's a French theorist that I think is apt, and that is that when we invented the plane crash. When we invented the ship, we invented the shipwreck. When we invented electricity, we invented electrocution. Okay, and now we've made AI, and I think it's going to bring about a lot of really wonderful and amazing, mind-blowing things. And it's going to bring a lot of bad and terrible and terrifying things. And so we need to organize, which is what we're doing, to guardrail against the worst scenarios and guide in the outcome that we want. And with that, I will thank you for your attention, and I will introduce Dr. Chu to take it over.
So hi everyone, and also hi to all the audience online. I'm Candice Chu, an assistant professor and clinical pathologist from Texas A&M University. And for the next 20 minutes, I'm going to talk about the application of AI in veterinary hematology and cytology. So just a little bit more information about myself. I received research funding from Every Cat Health Foundation. I'm the paid speaker by IDEXX and Health as well. And I unfortunately spread myself too thin because I'm too passionate about AI and education, so I got myself involved in various committees. A little bit too much. So before I start my talk, I would like to talk a little bit about deep learning. So we all know that artificial intelligence is the umbrella term that covers everything with simulation of human behavior. And under that big umbrella term, we have machine learning, which specifically refer to algorithms that can allow computers to identify and learn things without being directed to look for specific patterns. And under the term machine learning, we also have deep learning, which refers to those algorithms that can train themselves to perform tasks by exposing the multi-layered neural network. So within deep learning, we have so many different algorithms. For example, we have convolutional neural network, we have recurrent neural network. But today's talk is going to focus on convolutional neural network, which we call CNN. And what is CNN important? Because this is an algorithm that uses filters to identify features within the image. For example, like edges of the cell, the shape, the color, the corners, etc. And there are two most famous CNN algorithms that we typically use in the research. One is called YOLO, you only look once. So this is a CNN-based object detection algorithm that is fast performing and is optimized for real-time performance. And there's another one called RetinaNet that is specifically for small size objects, for example, like cells in cytology. So then we are going to look at some studies in veterinary hematology, and pay attention that I call study instead of studies because we only have one study. And this is the paper published last year looking to point of care platform and their performance on recognizing cells on the blood smear. So in the study, there are three different sections. The first section, they compare the performance of the algorithm versus the clinical pathologist in the 5-part leukocyte cell differential count. And they also look at the estimate of total leukocyte, platelet, polychromatophil, and as well as nucleated red blood cells. For the second part, they look at whether there are platelet clump present or not. And for the third part, and they specifically looking at the presence of polychromatophil as it is the indication for regeneration. And for all these three phases, they compare the sensitivity, specificity, and also the agreement. So for the first part, they found that looking at the 5-part leukocyte differential count, there's actually a pretty good agreement between the algorithm and the clinical pathologist. As you can see, is 91.7 to 96.6%. But when it comes to the total leukocyte, platelet, polychromatophil, and nucleated red blood cells, now the agreement is 70 to 95%. And for the identification of platelet clumps, the sensitivity is 90%, specificity is 88%. And for polychromatophil identification, that is 100% agreement. So actually, that study was conducted in a commercial company. So let's look at what are the current products that we are using on the market that they have AI ability. So as you can see in the illustration, this is a very small in-clinic scanner that you can use. So this scanner provides the AI blood smear application, which offers in-clinic blood cell analysis. And that includes, it will tell you the white blood cell differential count, the platelet count and platelet clumps, polychromatophil, as we know there are reticulocytes, and also nucleated red blood cells. And all these information will be to use to supplement the existing CBC data that we have. So how it works is that the veterinarians will get the information from the AI CBC report, but if they have any questions, they can always in the system to check and to request the pathologist to review the slides for them to verify the results. This one is called the InView DX Cellular Analyzer, and it also offers automatic morphologic assessments. And you can see that it has in-clinic blood cell analysis as well, which includes platelets, spherocytes, and other shapes of red blood cells, and also red blood cell agglutination, immature neutrophils, etc. And those information will be presented as fluorescent images, so veterinarians can look at those images and approve those findings, and those images will be integrated with the hematology reports. So some potential use that I see with these type of AI hematology products includes a detection of subtle morphologic changes that usually we don't pay attention to or the general practitioners are not used to find. For example, they may not be easily to identify those small dolly bodies in the cytoplasm of the neutrophils, so they may ignore toxic neutrophils. Also for blood parasites, for example, I work in Texas, so I don't really pay attention to look for like Babesia gibsoni or Babesia canis. It's not very common. So if there's an AI tool can screen the blood smear for me and let me know whether they exist or not, that would be super helpful because I'm not used to seeing those. I don't typically pay a lot of time to look for them when I review blood smear. And also for circulating neoplastic cells, it would be best if the AI tool can tell us, okay, what type of cell is this? Is this myeloid cell or this is lymphoid precursor? That would be super helpful for me as well. So I see these products can reduce the need for manual smear evaluation, and except for those that are really interesting case that being flagged. So even though that in our diagnostic lab, we have some criteria for blood smear review, oftentimes when I get the samples, they are still pretty boring. They may just have a little bit higher white blood cell count, but overall there is no significant findings. So I hope this type of tools can help us focus our energy and time on those really needed cases. Next, I'm going to talk about some AI studies in veterinary cytology. So back in 2021, there's a publication using YOLO version 3 to look at some neoplastic lesions in dogs. In this study, they have 1,219 samples, and they annotated 228,000 cells. These samples are from mast cell tumor, histiocytoma, and lymphoma. And then in the end, the algorithm achieved in 0.74 average precision. So when I see this number as a clinical pathologist, I feel like my job security checked. I don't have to worry about it. And later, there's another research group do a study specifically on equine exercise-induced pulmonary hemorrhage. So let me provide you a little bit of background about this specific disease. So we usually, to make a diagnosis, we have to look at the bronchial lavage, bronchial alveolar lavage, and then we look at those macrophages. They have to be stained with Prussian blue to show the hemosiderin within the cells. So as you can see on the image, each macrophage comes with a number 0 to 4, indicating different gradings of how much hemosiderins are inside the cells. And so the purpose of study is to see whether use of an algorithm can help them accurately and identify this total hemosiderin score to make a diagnosis. And actually, the degree of hemosiderin in the macrophage, there's a spectrum. So as you can see here, only a couple of cells really fit with the actual grading, but most of the cells are actually in the gray zone between two gradings. So how they're going to use the algorithm to solve this problem, they collect 26 samples from 25 horses and prepare the cytology smears and do Prussian blue staining, and then have one pathologist as the ground truth to label all the cells, and then invited 10 other people to do their own annotation as well, and then compare the performance of those 10 annotators versus the algorithm. So in the end, they found that they actually have a pretty high accuracy of 92.3% comparing the algorithm to the annotators. And personally, I'm very pleased with these results because counting 400 macrophages on cytology smear is not what I enjoy doing as a clinical pathologist. So happy for that. And in my lab, I investigated how those algorithms can accurately classify different types of lymphocytes within dogs with intermediate to large B-cell lymphoma. So in this study, I have 48 dogs, and I have 38 samples, lymphoma samples, and 11 non-lymphoma samples. And for each sample, I took 3 to 20 images under 100x OYO objective using the handheld iPhone 13. You have to have really steady hands to do that. And then in the end, I have 217 images for lymphoma cases, 85 images for non-lymphoma cases, and then I label every single cell within those images. So in the end, I label more than 11,000 cells, which takes a lot of time. And then almost 5,000 of them are large lymphocytes, and I have 1,700 intermediate lymphocytes, almost 5,000 small lymphocytes, and I have 270 neutrophils. So how are we going to do with these label data? We are going to split them into 3 different groups. Using the RetinaNet algorithm, they are split into training set, validation set, and testing set. And then as they're being passing through this multi-layer neural network, we are going to do 2 things. One is to classify what type of lymphocytes they are. The other thing is to localize their position on the image. So this is the output from the algorithm. It will tell me what type of lymphocytes they are by different color of bounding boxes, and they will show their location on the cytology image. In this study, I define lymphoma as there are more than 50% intermediate and large lymphocytes among all lymphocyte populations. So here's the preliminary results that we have pretty good accuracy, except that we missed 1 case because we only have 13 cases in the testing set. Sensitivity, we have 1 false negative cases, but we also have pretty good specificity and precisions. So for this ongoing study in the future, I'm going to recruit more cases, especially the non-lymphoma cases, so I can validate the finding of this algorithm. So next, I'm going to talk about AI cytology products. And how this is made possible in veterinary medicine is because the development of digital scanner. So traditionally, if you want to get a diagnosis by a clinical pathologist, you have to make your slide, you have to ship it over to the diagnostic lab. When it arrives to the lab, you have to wait for the clinical pathologist and then put it under the microscope to get you a diagnosis. However, now we have access to those in-clinic digital scanners. We can easily have 24/7 cytology services. Those smears will be scanned, the file will be uploaded to the cloud, and then clinical pathologists work globally, will look at it whenever you are, and usually they can have a pretty quick turnaround within 2 hours. So what are current products that are actually using AI in cytology recognition? The first one, of course, is also the Zoetis VetScan Imagist. They just recently announced that they offer AI-based cytologic analysis, specifically focusing on common lymph nodes and subcutaneous masses. However, this function will be launched, according to them, second quarter of this year. And the competitor, IDEXX, of course, they also incorporated this cytology service in their InView DX cellular analyzer. They plan to launch the cytology support in the near future, but we don't know when. So after talking about all the products and using AI in hematology and cytology, I think it is really important for us to look at the quality assurance in those enhanced veterinary diagnostics. So very recently, the same research group published this 2-part review articles in veterinary clinical pathology, talking about different things you need to pay attention to when you publish this type of products. And so I compared those 3 publications with the criteria mentioned in the review article. And as you can see here, most people mention you have to identify your intended purpose of your publication. You have to say how you get the data sets and describe the data set, and also what are the metrics you use to evaluate the performance of your algorithm. However, in terms of bias, calibration, runtime monitor, and stress testing, none of the publication mentioned those criteria. And some publication mentioned about uncertainty, or partially mention robustness or repeatability. So this shows that really for this type of study, veterinary medicine is still in its infancy, and for the future studies, we need to pay attention that we do a really good quality assurance. So for my talk, I just wanted to give you some quick examples to show you that AI integration is something that's actively happening. So we need to pay attention to what are the available products in the market. And I'm assuming those products will be available very soon. Also, hopefully these products can help us increase the diagnostic speed, and hopefully during the rigorous development of these products and the involvement of pathologists, those products can really give us accurate results. And as I mentioned, quality assurance would be very important in the development of this type of products. And last but not least, I think position statements from veterinary organizations are very important. So 1.5 years ago, Canadian Veterinary Medical Association has published this position statement about artificial intelligence in veterinary medicine. And very recently, ACVR and ECVDI also have this joint position statement published, which is nicely written. And then AAVSB also released this regulatory considerations of the use of artificial intelligence in veterinary medicine. So as Dr. Cohen mentioned, that there's actually no regulation of FDA on veterinary product. So I think that makes the position statement from our organization, especially the specialty organizations such as ACVP, ASVCP, would be most important for our society. So you can find all these references in my proceedings as well. And lastly, I not only study AI, but I also teach AI. So I'm proudly to share with you that I'm going to start the very first artificial intelligence course for our veterinary student at Texas A&M University starting spring 2026. And if you are an educator or if you are passionate about AI, you want to know more about it, you're more than welcome to scan the QR code and have access to my teaching material. Thank you.
Thank you so much, Dr. Chu. Dr. Cohen's going to join us as well.
Great job.
All right. So you both spent a lot of time talking about quality assurance of these products that are currently available and that will be coming. And it's clearly really important that they're properly validated, that they're safe, ethical, accurate, and all of those things. The end users are often not going to be subject matter experts. And so how do those of us that are sort of in the trenches, how do we assure that all of those things apply to a specific product? How do you recommend that we navigate purchasing and using a specific product?
Would you like to?
Yeah, I think people have to upskill. So I think part of that is talking with our colleagues and us all learning together. There are things that are out there. There's something called GMLP, Good Machine Learning Practices. So there are things that are established of what is just baseline accepted. This is what we think is defensible AI or not. I think have a look at some of those position statements. Part of the comment in that article that's just out in JAVMA, which is from the ACVR AI subcommittee, is that there's a statement in there that says we currently do not think that any of the products meet the recommendations for safety, transparency, or validation. And that's not just me, that's a whole committee of folks that are domain experts. And hopefully that's meaningful. But I think the end user, to your point, is going to have to be the arbiter to demand a certain kind of a product to say, what are the training sets and the validation sets? What error reporting are you doing? How are you looking for drift? Right, all of these things, we have to learn to demand that, just like you'd learn to engineer a prompt for ChatGPT.
And my recommendation would be always pay attention to whether that product comes with scientific publication that's been peer reviewed. And also that goes back to our veterinary education. That's why it is important we have to teach our students about artificial intelligence and those criteria that they are going to use while reviewing their scientific publications.
Thank you. Is there a question in the room?
You both touched on job security, and I'm wondering, what do you see the challenges in the industry for the rest of the team in the veterinary clinic, the vet techs, the practice managers? Should they be worried?
Want to take that?
Yeah, I always said to other people, like my audience, when I speak at different conferences, is that AI will not replace you, but your colleague who knows how to use AI will. So definitely pay attention to learn how to use the tools. And I know that we always said that AI will not replace pathologists, but I do think that with the availability of AI tools, we became more efficient in our work, and then we can definitely tackle more cases. At the same time, however, if the presence of AI can reduce the cost of cytology submission, then maybe there will be more cases and eventually will not actually take out our job security?
I would say yes. I think it's going to come for everybody. And if we, as veterinarians, I think we look at the world in a certain kind of a lens. If you are a finance person or a business person or you work in private equity, you look at this for a very different lens. And employees are fixed costs. And if you can use a chat bot or a receptionist bot or something instead of a human that you save money on, I would be a hard argument why you wouldn't if it was useful, right? So I think we would all, it would behoove us all to think about how do we not only ensure relevance for the sake of relevance, but what are we adding to the picture and how do we usher this in so it is augmented and value add and not instead of. But I think there's a lot of things happening in the vet profession, corporatization, VPA, rolling back parts of the VCPR. Depending on what lens you view those things through, those could be improved access to care and spectrum to care, or those could be tip of the spear for job replacement. And so I think we need to remind ourselves that not everyone is a veterinarian who looks at the world the same way as everyone outside of our world.
Another question in the room.
Yes, thank you. I practice at the University of Georgia, and right now in Georgia, I didn't realize how lucky we were that we do have some rules around use of AI. And so right now I have a little macro in my medical record where we have to list specifically that we're using AI. We have to list the specific technology. We have to list the date that we got the owner's verbal approval to use that technology before we start using it. We have to list who reviewed the technology to make sure it was accurate. And then there's, of course, a statement that the AI is not practicing veterinary medicine that we are. And so it's very interesting. We start each one of our telemedicine consultations with all of these disclaimers. And if the owners say, no, I'm not comfortable, then of course we're not going to use it. And we'll make that note for future reference. What would, being experts in this area, what would you like to see in the US as far as, rules and regulations? Do you have sort of a top 5 things that you want us to be doing so that people can start doing it even if their state doesn't have rules?
I think what you're doing is great and is very thoughtful and forward thinking. And consent is a component of the VCPR and consults and referrals, and I think owners should be aware if that's part of the decision-making chain. And if they get educated and ask you, like, how did you guys validate this product? We should be able to answer that. So I think that's really important. I do mobile ultrasound as part of my practice. I've already started seeing practices that are using this ambient record-keeping technology, having signs in the room that you are being recorded and you can opt out if you want. So you can start to see how this starts to change the profession. And I think if you don't, it will just require an index case to be brought to task and then it will be out of our hands, right? So I think things that meet good machine learning practices, I think consent and transparency are really important. And I think just being conscious of how, as I mentioned, our biases can be exacerbated by these efficiency tools. And so I think, and at the end of the day, you'll have to decide after you do all of those things, was it a value add to use that or not?
Sometimes it actually slows us down a little bit, right? Like I think sometimes, for my residents, it makes them maybe perhaps focus on more detail that was recorded using that program than was probably necessary for, say, the medical record. And so it's incredibly helpful for certain aspects and going back and collecting, parts of the history and reviewing things. But I think there are some parts that may actually slow us down at this point.
I feel like this is something that we should do, veterinary researchers who are passionate about AI, we should do more this type of study to validate these products. We have so many this type of AI scribe products that are currently available. Nobody actually look into their accuracy, and there's no comparative study on that. I think that's something we should be really doing.
And hearing from folks, there are folks that are early adopters and tech forward, and there's people that still have not heard of ChatGPT. So we're a pretty heterogeneous profession currently on this topic, and I think hearing use cases and what's working and what's not working from both users and companies in a transparent way would be a great way to improve adoption of good products.
Thank you so much to Dr. Cohen and Dr. Chu. Very intriguing presentations. Thanks so much.